Invitation. It's a pleasure to be here. I've only had a few interactions with Bob Gillis. Started in 2019, but very quickly, I absolutely appreciate the comments that were made on mentorship. I was introduced through Philippe Lambin, who's a close collaborator, and very quickly recognized the type of question he asked me about really getting to what I was passionate of studying. And therefore, the title of this talk, we really discussed the effect of imaging over time and how we could perhaps capture some of these changes. And myself was always intrigued by not only the power of imaging as a good detector of change, but also making sure that we create an environment where imaging we can have competition with other data elements. So we really started to discuss the infrastructure, and this was through probably less than 5 discussions, but really guided all of the work that we did over the past 3 years on creating an infrastructure to tackle big questions. So we'll share some of our progress. To Andre's analogy and the work on trains and train stations, we've been focusing only on one train station, just trying to understand how messy that is in one place and trying to see how to do this broadly. But it's been really just focused at UCSF. A lot of people to thank at UCSF, and also a lot of collaborators that have contributed to the work. So my interest is really on broadening the optimization problem. So I'm a medical physicist. When we have a set of rules and a very clear goal, we can certainly develop an optimization, and we've done so over the years in the case of really just inverse planning, for example. So what if we then apply this to more advanced technologies? I'm more interested in on the right side of the optimization of cancer care trajectories at the personal level. And what David Jeffrey has been describing as the learning machine, we really do need an infrastructure and an optimization engine, and it goes down to the simple representation of data to the patient level. So I'll share some of our thoughts on this. And again, this is really a focus just at UCSF. This is a little bit the secret in the sauce. It's not necessarily innovative per se, but this took about 2.5 years to develop, and mainly that little green database icon where it says Clarity EHR. This was a highly iterative process of going to extract every 24 hours. Any patients treated gets processed and de-identified in our system, and create a medical profile for each patient that we can then process, identify, compare in many ways, including digital twins. So the way it works is we went back to the fundamentals of learning and focusing on the components of learning. And you can see here on the patient medical profile, just characterized here with different spheres of colors, which are different data types, and the sizes would be the importance of those data types for a given studied outcome and why. So we were trying to find a target function F that will model a population of X and Ys, so patient characteristics to patient outcomes. Obviously, we have those historical records. This is not in the context of clinical trial, but with the messy data of hospitals today, particularly big academic centers. So we will then generate a number of hypotheses that we hope will track the target function. And so the components of learning for an unknown target function is using those training example that I mentioned, and to create a learning model that we will use a number of hypothesis sets in order to find a final hypothesis that will track ideally our target function. Some of the discussions that I had with Bob on this was an issue of overfitting, particularly on generating a lot of features on imaging. And so fundamentally, in regard to this learning model is what is the likelihood of having 4 heads in a row? It's unlikely, but if you play that game 1,000,000 times, it's nearly 1. So obviously this came down to very much carefully designing experiments, particularly because they are not independent experiments. So we've built a little bit of that in mind as we now added the time component to really study care trajectories. We've shared some of this progress recently in the literature with many collaborators, and it was really just more setting up the framework, which took a lot of I've probably got a few scars to show along those ways, is to combine not only for radiation oncology, but for oncology at large. So there's no way that we can identify, in my opinion, the value of imaging without all the other components. And that, therefore, it's such a massive undertaking. But we started small by combining on the left multiple data sets over time, and then built a computation platform in the middle that process these data elements, all with the idea of creating an individualized patient profile. So we actually did not focus on standardization at first, just realizing we're too small, and some of these efforts to combine all data elements will come over time at some point, but we should have at least a representation that can be mapped or bridged at some point in time. So we started with one cancer type, in this case, meningioma, basically combining different features over time and generating prognostic models. And you can see, certainly we had the intention of adding radiomic features along the way, all with the intention of studying local failure and overall survival for this patient population. So we had about a little bit over 300 patients with very comprehensive clinical imaging, molecular data, and looked at patient outcome. For those not as familiar with meningioma, it's actually not a very aggressive cancer. It's probably on the other end of the spectrum compared to GBM. So the vast majority of patients do well, but there is a 20% of patients that absolutely do not do well, will exhibit a lot of recurrence. And so we were certainly interested in building a data set that would study that 20%. So we built a number of machine learning models with all the features that had been accumulated, again, looking here at the feature importance for local failure and overall survival. I share some of our results here. It's not meant to be fully readable, but I'll just explain some of the discussions I had with Bob on this, and it really pushed me in a new direction. So it was really not just by asking the question to ultimately the surgeons, the radiation oncologists, I was really not sold on our highest performing model, which was a radiomics model. Despite all the attempt to be very robust in the analysis, just could not see this being accepted in the clinic, and I could see a lot of the questions. So ultimately, we designed our study with a clear intent to have as few as number of variables as possible. And we landed actually on 3. So we used, to maybe the whole purpose of the discussion with RECIST and using volumetric data, we actually just focused on the volume, but also the sphericity of those lesions. So even before going now in surgery at UCSF, the sphericity of those tumors, so a tumor that could be very spherical but large, may not be as aggressive as one that is small and highly non-spherical. And it is being used as a precursor to how aggressive the surgeons will be in the OR. Of course, they base their final decision on biopsies and tissue sample during surgery, but at least there is a clear kind of expectation going in. And you can see here in the way that sphericity alone as one feature was really driving a lot of survival down the road. So the discussion I had with Bob was more on, what is more useful, the one that is most accurate or the one that ultimately surgeons and others will understand. And so it really pushed this in a new direction for other cancers, including how we started to study breast and lung cancer using real-world records within the institution, despite all the difficulties with this data. So we built a lot of the models for both of these cancers. This is, again, just predicting the 5-year survival for breast cancer and the 2-year survival for lung. And because of the amount and the diversity of the data within the institution, again, not in the context of clinical trial, and looking at the multiple classifiers and the variable importance, we did discover things that are non-traditional, including how far patients live from primary care centers, the level of education, whether patients were married or separated. But we also found the traditional, obviously, staging, also the clear imaging findings on tumor size and sphericity, and cardiovascular risk as well. So it was kind of a new way, and none of this is ready for implementation, but it was more of an exploration that really confirmed the importance of really looking at all elements and not one or a few in isolation. Speaking of robustness, those were also discussions I've had with Bob. So we looked at Traditionally, when you have a large data set, we do random stratified split of the data for training and final testing with a holdout test set, but really looking also at doing time-based splits to make sure that the findings are really robust. And in our 10 years of data at UCSF, it's certainly held pretty well for lung cancer, but completely fell apart when we looked at breast cancer. This is being studied at the moment. It just showed, how careful one needs to be, perhaps telling us a little bit how the field has changed for breast cancer. I don't have strong conclusions in that just yet. We started to use other elements as well, not just imaging for predicting trajectories, including medical text. It was mentioned, I think, earlier today that 80% of it is on unstructured information and just really kind of trying to capture knowledge, which is a lot in text as well, not just in regular notes, but imaging notes, pathology notes, and so forth. So we ran a very simple feature extraction, the way we run feature extraction for radiomics on text. This is not novel and not difficult. This is actually a very well-established methodology of TF-IDF. It's looking at term frequency, inverse document frequency, and really looking at rare words, and then running through a simple logistic regression on those physician notes. And what we found is, again, speaking to the trajectories, you can see here on the x-axis the number of days that are included in our statistical model using these feature extracted for both breast cancer and glioma. And you can see that the slope is positive, meaning we're getting better and better at predicting who will survive and who will not at those binary endpoints. And then identifying which words were actually more important. So speaking perhaps to the interpretation of what the model is really doing. Very simplistic. This is absolutely not a model that would need to be implemented in the clinic, but it's a first step to be applying even more complex models that are not just one word at a time, but multiple words as well. So certainly a new direction that was published in that Nature Cancer paper that we're continuing to develop, including the development of transformers. What we found thus far is that data quality and certainly the sources of bias have to be dealt with carefully, and source of bias are many. The regional bias, in our case, the Bay Area, the institutional bias, that could be UCSF versus Stanford, for example, is a real thing. We are known to be better at certain things than others, and we attract different population. The selection bias of who we include or not, we rejected, for example, in our study, patients that had not a high volume of records or not enough continuity, but that is a bias by itself. The information bias, what we have on hand to play with and develop models is a source of bias, as well as which algorithm is ultimately used. Always a balance of accuracy and robustness, but certainly I've discovered myself that I would value robustness over accuracy most of the time. In summary, oncology has become too complex for a whole team. So data science and real world data could help generate new hypotheses and perhaps more targeted clinical trials. We're developing patient temporal data representation and methods to study continuous learning on individual patient trajectories, to explore new hypotheses with this data and really develop robust models. And a lot of this was literally in probably less than 5 discussions that I've had with Bob when I joined and participated in these meetings over the years. So very grateful for a very effective way of kind of catching what you're passionate about and pushing you to think about it in a good way. So thank you very much again for the invitation, Isam.
We have